The photomicrograph displays a definitive positive result for the indirect fluorescent antibody test utilized in the diagnosis of Toxoplasma gondii, which is an obligate intracellular parasitic protozoan of the phylum Apicomplexa. The underlying principle of the indirect fluorescent antibody test involves a two-step process, where patient serum or a known positive control is first incubated with fixed tachyzoates that are immobilized on a glass slide. If specific antibodies are present, they will bind to the surface antigens of the tachyzoates. In this specific image, the yellow-green fluorescence appearing around the periphery of the crescentic organisms indicates the binding of fluorescein isothiocyanate conjugated antihuman globulin to the primary antibodies that have successfully complexed with the tachyzoate surface. Toxoplasma gondii is typically transmitted through the ingestion of undercooked meat containing tissue cysts, or through the accidental ingestion of oocysts, shed in the feces of cats, which serve as the definitive host. In the United States and other developed regions, the most common presentation of primary infection in immunocompetent hosts is an asymptomatic or mild mononucleosis-like illness characterized by lymphadenopathy and fever. This condition typically presents as multiple ring-enhancing lesions on contrast-enhanced computed tomography or magnetic resonance imaging, and must be differentiated from primary central nervous system lymphoma. Congenital toxoplasmosis occurs when a mother acquires a primary infection during pregnancy and is classically defined by the Sabin triad of chorioretinitis, hydrocephalus, and intracranial calcifications. The tachyzoite stage seen here is the rapidly multiplying form responsible for tissue destruction and acute symptoms, while the bradyzoite stage is found within slow-growing tissue cysts during the latent phase of infection. Diagnostic confirmation often relies on serology looking for immunoglobulin M or immunoglobulin G titers or polymerase chain reaction of amniotic fluid or cerebrospinal fluid. Treatment for symptomatic infection or toxoplasmic encephalitis involves a combination of pyrimethamine and sulfadiazine along with leucovorin to prevent bone marrow suppression. Prophylaxis with trimethoprim sulfamethoxazole is indicated for human immunodeficiency virus patients with a positive serology and a cluster of differentiation 4 count below 100 cells per microliter.